Good afternoon. My name is Joe Antos. I'm the Wilson H. Taylor Scholar for Healthcare and Retirement Policy at the American Enterprise Institute. I want to welcome everyone to today's discussion of the 2022 Medicare Trustees Report. The Trustees Report was issued last Thursday, as I think you know, and we are honored to have Paul Spitalnik, the Chief Actuary for the Centers for Medicare and Medicaid Services, to explain how the program's fiscal outlook has changed since last year. There is a tiny bit of good news. The Health Insurance Trust Fund is projected to run short of funds 2 years later than last year's estimate, 2028 instead of last year's estimate of 2026. Okay, well, now that we've got that over with, let's turn to the bad news. Over the next decade, Medicare spending is projected to exceed $13.8 trillion. Medicare revenue will fall short, but not by much, at least by modern day standards, $13.5 trillion in revenue over the next 10 years. However, only about half that amount comes from payroll taxes, premiums, and other revenue dedicated specifically to Medicare. About $6 trillion comes from general revenues, primarily paid into the trust fund that finances Medicare Part B and Part D. But that $6 trillion is not just lying around somewhere at the Treasury waiting to be spent. The federal government is running an overall budget deficit, as everyone knows. That means we are already borrowing to keep Medicare benefits flowing, and the amount we must borrow will only increase over time. This year alone, Medicare will receive over $400 million in general revenue, which means that Medicare will be responsible for an additional $400 million worth of borrowing, federal borrowing. The program is literally living on borrowed time. Now, clearly, Medicare, and people have been saying this, the trustees have been saying this for many, many years, Medicare is not sustainable unless things change, clearly. Policymakers will need to take action, but perhaps even more important, the health system needs to find ways to deliver care more efficiently to patients. And that's where the Medicare program is really pivotal. Medicare is the biggest health insurance program in the country and has the power of government behind it. When Medicare policies change, it fundamentally influences the way healthcare is delivered throughout the system and not just for senior citizens. So Medicare policy is really critically important here to resolving our longer term financing problems for American healthcare in general. Now, one other aspect of this having to do with the trustees report, obviously the trustees and the actuaries are not fortune tellers. They do projections based on recent trends in the economy and recent trends in spending and so on. And they also assume, understandably, that current laws will remain in place without change. They don't have any basis for predicting how laws might change, and that really is something that is up to Congress and not something that the Medicare trustees can directly deal with. But obviously, the thought that current laws would continue on unchanged is implausible. So accompanying the main trustees report, there is an illustrative scenario that points out that formula-driven cuts in the Medicare program, in Medicare payments rather, would eventually threaten access to care for beneficiaries. And that would force the hand of policymakers to take some action. The point is that set it and forget it policies are included in major legislation, such as the Affordable Care Act, but a lot of other legislation as well, to get a favorable CBO score. But those policies are not sustainable indefinitely. Congress eventually moderates such policies. We've seen that in the past. We'll see that in the future. That means higher program spending and a more unfavorable outlook for Medicare's trust funds in the future. Structural reforms rather than simple payment cuts are needed to set the program on a fiscally sound path that maintains appropriate support for the health of Medicare beneficiaries. Now, let me introduce the panel. I've already introduced Paul Spitalnik, who will lead off. Then I'll name people in the order that they will do their formal presentations. Gene Sterling is an Institute Fellow and the Richard B. Fisher Chair at the Urban Institute. Among his many accomplishments, Gene was Deputy Assistant Secretary of the Treasury Department. He is a co-founder of the Urban Institute Brookings Tax Policy Center and is the author, co-author, or co-editor of 18 books. Gene, I'm not sure I've read 18 books, and you've written them. Paul Vanderwater is a senior fellow at the Center for Budget and Policy Priorities. I met Paul at the Congressional Budget Office, where we both worked back a few decades ago. Paul was the Assistant Director for Budget Analysis. In that position, he led the group of analysts who produce CBO's estimates of the budget impact of legislative proposals, which basically meant that during some times of the years, he really didn't get much sleep. And then finally, Juliet Kabansky. Juliet is the Deputy Director for Kaiser Family Foundation's program on Medicare policy. She is the author or co-author of literally hundreds of reports and articles on Medicare, Medicaid, and private insurance. They are among the best sources of explanations for how these programs actually work. And Juliet and her colleagues deserve an awful lot of credit for not only informing the general public about how things work, but also, frankly, reminding those of us who claim to know how they work, just exactly how does it work. And so with that, Paul Spitalnik, take it away. Thank you.
Thanks, Joe. I'm about to share my screen, so just bear with me for one moment. And I'm having trouble finding my screen, so I apologize. But it is my pleasure to be with you this afternoon and to represent on behalf of the Office of the Actuary, the dozens of professionals that work in our office that support the Board of Trustees each year. I'm going to talk through the current report, the key findings of the current report, talk through the current snapshot and how the program has evolved over time, look at the key results from this year's reports, and focus a little bit towards the end on just the impact of the COVID-19 pandemic on the projections. This is just an overview for those that are less familiar. Medicare trust funds, there are two Medicare trust funds, the Hospital Insurance Trust Fund, which includes Part A, and that is generally the acute care services, inpatient, skilled nursing, and the like. There's also the Supplementary Medical Insurance Trust Funds that includes both the Part B and the Part D programs. Part B includes most other medical services, so physician, outpatient services, testing, and the like. And the Part D program is the prescription drug program. These programs are all financed differently and separately. So to the extent that there is financing available in one of these trust funds, that cannot be used to pay for benefits out of a different trust fund. And so when we do go through and evaluate the status of the various trust funds, it is important to look at them individually. The Hospital Insurance Trust Fund, Part A, is funded primarily through payroll taxes that are paid by workers and their employers. While the Part B and Part D programs are predominantly financed through premiums with general revenue matching. So effectively, the Part A trust fund, that's the one that typically gets the most attention with respect to the trust fund reserves and when those reserves are anticipated to be depleted, while the Part B and the Part D programs are the financing is set annually on those bases. So those programs are automatically or always in financial balance. This just looks at how these programs have evolved. One of the purposes of the trustees report is to project the Medicare program over the next 75 years. This just highlights how the program has changed over the last 40 years. You could see that these charts look extremely different. They have clearly have gotten much larger over time. It's not represented here, but you can see from 1.37% of GDP in 1981 to 3.77% of GDP in 2021. And the distribution and the services that are provided have changed significantly over time. This is just to highlight that these programs this program is ever changing. There are regularly significant forms of legislation that change the programs, and the programs are constantly in change. And so to the extent that we are sitting here today in 2022 looking to forecast what the Medicare program is going to look like in 75 years, I can say conclusively that we are going to get it wrong. However, we're going to do the best we can in terms of trying to model both the short-term and long-term trends in terms of determining what the impact of the program will be over time. Joe highlighted the key takeaway that what gets the most attention from the release of the report each year, and that is with respect to the trust fund depletion date of the HI trust fund. And this year it is 2 years later than estimated in last year's report. This is largely due to income being projected to be higher than estimated in last year's report. And show in a brief moment that the short-term expenditure is a little bit lower, but then will increase over time as higher payment rate updates will start to kick in. What typically gets asked with respect to these programs is how has COVID-19 affected the programs? And this is a quote from the 2022 Trustees report. So while the COVID-19 pandemic has significantly affected Medicare short-term financing and spending, it is not expected to have a large effect on the financial status of the trust funds after 2028. It is obviously early to know this conclusively, but these are the basis of the assumptions of the trustees at this point. We'll mention that there has been this Medicare Accelerated and Advanced Payments Program that basically advanced a lot of funds to providers in the midst of the pandemic when utilization was relatively low, and providers were having challenges with respect to certain revenue streams. $107.2 billion was paid out. These are dollars that are expected to be repaid back to the trust funds. And so while this does have a significant effect on the cash flow of the various trust funds, in the end, it is not expected to have any material effect on the financial status of the trust funds. But it is something to keep in mind as looking at the different flows of the different trust funds, that they are significantly affected by the significant dollars going out of the trust funds in mostly 2020, and then reductions in expenditures in 2021 and 2022 for providers repaying these advancements. So with that said, this is the comparison of what was projected in the trust funds from 2021 to 2022. Looking at income separate from expenditures, you could see the total income changes of $88.4 billion over this 5-year period was quite substantial as compared to the expenditure differences, which was only $13.1 billion. So a short answer to the question of, why is the trust fund in better shape this year than it was last year? It is largely a revenue story. It is largely attributable to the economy rebounding much faster than anticipated in last year's Trustees report. That said, there's also certain expenditure impacts and also some lasting revenue impacts as well. But largely, this was an income revenue story. On the Part B side, there was a little less actions on the expenditure side. There was some more significant changes on the income side, and that has to do with how the Part B premium was set for 2022 in anticipating the potential effects of a new Part B as in boy drug that would be used to treat Alzheimer's that was loaded into the 2022 Part B premium rate. Turns out that both the price of that fairly expensive drug was reduced significantly, and the coverage determination for this new drug, Aduhelm, was quite limited. So, in fact, actual expenditures for this drug are expected to be relatively minor in the Medicare program for the next several years. What you can see here is the short of it is that there is additional income, a higher premium effectively set for 2022, but that mostly gets offset through lower premiums in future years. So with that great news of a 2-year later depletion date, it doesn't really change the view of the trust fund status all that much. It is certainly better to be depleted in 2028 than it is to be depleted in 2026. But this picture still shows that the trust fund income is not going to be sufficient to cover trust fund expenditures in a relatively short period of time. So the big picture is not particularly changed. This looks into the financing of the programs. So you can see how the financing of the different programs change over time. I apologize for the phone call in the background. You can see how the financing of the programs change over time. You could see how payroll taxes as a share of GDP is relatively constant. That's because the payroll tax rate is fixed into law, and so that doesn't change materially over time. But as Joe alluded to in some of his introductory remarks, where a large and growing share of the financing for this program is with respect to federal general revenue transfers. And so this does place a greater strain on the federal budget. So focusing on depletion data is looking at a relatively short-term impact. Looking at the cost rates, the actuarial balance, this would suggest what the change in the payroll taxes would need to be in order to adequately finance the Part A program over a 75-year period. So you can see this was also improved in the 2021 report. It was 0.77% of taxable payroll. In 2022, it's 0.70. Again, improved economy, improved the amount of income coming into the trust funds, and therefore the trust fund, the actuarial balance was modestly improved. Again, with all that good news, the actual story, and Joe alluded to this again in his remarks, what's included in the report is the comparison of those two black lines, the current law income rate versus the current law cost rate. That assumes that provisions of current law that are restricting the updates for certain providers are constrained, and to the extent that those constraints are going to be realized indefinitely into the future, then cost rates will be controlled. However, that would suggest that payment rates would increase at a slower rate than the underlying costs of various providers. And so the trustees request that we prepare an illustrative alternative scenario. And here you can see that in that scenario, those longer run costs would increase at a rate that's more comparable with the history, and that's longer. Those deficits, the difference between that top red line and that bottom black line, would be much greater than what's presented under current law. While I'm talking about the illustrative alternative, I did note in the actuarial opinion, when we typically talk about these potential concerns with respect to current law, generally they're spoken of at some point into the future. This year in actuarial opinion, I actually highlight that there might be some more immediate concerns with respect to some of the physician updates. In 2023, there's a negative update for physician payment rates. In 2024 and 2025, those rates are expected to be zero. In 2025, a bonus is expected will expire. And so there is a discussion of, there might be some more immediate concerns with respect to current law, with respect to payment rate updates for physician services. So now I'm going to start to kind of transition and talk a little bit about what are the effects of COVID on the projections. And this here I'm comparing the 2020 report, which was effectively on a pre-COVID basis, to the 2022 report, which obviously reflects our current thinking on what the impacts are with respect to COVID. And you can see here on the Part A expenditures, there were some pretty significant decreases in 2020 and 2021, and those are expected to persist, fairly significantly throughout the next several years. There was on the Part B side, there was an even more pronounced reduction in 2020, but there was also a faster rebound as well. And so as we've tried to get a better understanding for why have expenditures changed, there are a number of reasons why this could be. Clearly, patterns of beneficiary use of care during the course of the pandemic changed significantly. There was a lot less doctor visits. Elective services were delayed or deferred. So there was an increase in telehealth services, people using their phones or computers to get some services met. But there was also potentially some demographic effects. Clearly, COVID had a significant effect on the Medicare population, and there were a significant number of additional deaths in the Medicare population. And so we tried to study and understand, well, did those population changes affect Medicare spending, or how did those population changes contribute to some of these differences? This is just looking at some of the different services. You can see some services were more greatly affected than others. So things like home health agency had dramatic reductions. But even if you look at the blue line, inpatient hospital is one of the largest categories of fee-for-service spending. There was a pretty significant reduction in 2020 and 2021. And on Part B, similarly, there were a lot of reductions in 2020. You can see there were some increases on some of, in particular, with respect to some lab services. So specifically, COVID testing was something that was not anticipated in 2020. So again, looking to try to understand. So here's some of the more age, sex adjusted mortality for the Medicare program. You could see that the rate was relatively constant 2017, 2018, 2019, and consistent with the trustees' assumptions that there was generally mortality improvements over time, which is generally what we've experienced, for most of the program's history. COVID hits, and there's significant excess deaths, and so how did that affect? Did that contribute to some of the Medicare expenditure differences? And so we were able to do some analysis, and I promise I will not get into the weeds. I know most on viewing this are not actuaries, and so I will not bring you fully into the world of the actuary here. But you can see here, so we've looked at things in two different ways. We looked at on a risk score basis and on a spending basis. So looking on a risk score basis, you can see total risk scores. There's generally these will average 1.0, so the total fee for service AB that will average 1.0 each and every year. There's an MSP adjustment, a Medicare secondary payer adjustment that's not reflected here, which accounts for about the 1.5 different. So let's just push that aside for a moment. But not surprisingly, when you break apart those the total risk score between those that die in a particular year, the decedents, and those that survive in a year, you can see that they are significantly different. That those that die typically have a significant amount of additional healthcare needs, have additional healthcare diagnoses, and you can also see that these are somewhat surprisingly, these are relatively stable. And you can see from the 2016 to 2019, these ratios between total decedents and survivors are relatively constant. So now when you see in 2020, when there's a significant amount of excess deaths, you can see that the decedent risk score declines significantly. The total risk score drops somewhat, as does the survivors. And we were able to identify the number of likely COVID decedents. And you can see that COVID decedents were still very expensive, still had a lot of comorbidities associated with them, but less so than decedents in a typical year. And what you can conclude from that is that those that did die from COVID had much higher than average healthcare use, but not as high as what we would typically expect from those that are decedents. And so when you pull that population out, you're left with what's the effect on the survivors. And you can see here that the survivors are roughly 2.1% lower than in a typical year. And the total, the 99.6 is 1.8% lower than in a typical year. And so you can conclude from here that those that are surviving, you're just looking at it from a risk score basis, are in this, higher, almost 2% healthier than a typical surviving population. So that is one cut of trying to understand the demographic difference. This is the second cut here, and this is looking at spending in the prior year. And so obviously spending was significantly affected in 2020, but instead of looking at spending in 2020, we were able to look at spending in 2019. And here you could see something very similar. Total spending is in that first column, the survivors in the second column. The decedents, again, follows a typical expected trajectory, much higher than the average. But then when we compare COVID decedents to other decedents, you can see that they were lower, that they had lower prior year spending than the typical decedent, but much higher than the average. And when we put all this together, we can make some estimate that that surviving population, if not for all those excess COVID decedents, would have been roughly 1% lower than what it would have otherwise been. And so kind of pulling all this together, there were a couple of effects that were built into this year's report. The conclusion being that, at least in the short run, the additional COVID-related deaths will have an effect on per capita spending in the near term. The quantification of that was that spending was about 1.5% and 2.9% lower in 2020 and 2021. due to these excess COVID deaths. Those effects are expected to remain for several years, but will phase down to zero over time. And so just wanted to kind of highlight that as something that hasn't gotten much of attention and is reflected in the relatively short-term trustees projections. So with that, I think that concludes my remarks. I'm going to stop sharing and send it back to Joe.
Thank you very much, Paul. That was those results about COVID were particularly interesting to me. Perhaps when we get to the general discussion, we'll dive into that a little bit. I, of course, as I often do, forgot to mention that if people have questions, and we welcome those questions, and it would be best if you were to send an email to Cameron Tarbell at aei.org. That's CAMERON.TARBELL at aei.org. The other alternative is to use Twitter, although that's actually less reliable. Hashtag AskAEIHealth. I should have said that earlier. Thanks very much for your patience. Gene Sterling, you're up next. Gene, you're muted.
Can you see the share screen?
Yes.
Okay, good. Okay, thank you. So that was absolutely terrific presentation, Paul. Really respect all that you and your office do. My talk is going to go a little bit, maybe more even to 30,000 feet, and basically argue that Medicare is not just a Medicare, even primarily a Medicare issue, particularly when we're talking about the cost of the system. I should mention that a lot of my comments come from work I've done for the Arnold Foundation, for the Peterson Foundation, and with the Urban Brookings Tax Policy Center. And the comments are my own, obviously, and not those of those organizations. If you'd like to get in touch with me to have access to some of this other work as it comes out, please do so. I have my email here at the beginning and the end of my talk. So by way of background, I really like to start off, as I said, I have great respect for Paul and his work. The Office of the CMS Actuary, Chief Actuary, is actually one of the finest, most professional offices in government. Now, some of the people there may be geniuses. I'm not sure about that. I'm always warned by Joe Theismann, who, at least referring to football players, said nobody in football should be considered a genius. A genius is someone like Norman Einstein. However, they come about as close as you might want. And the main point I want to make is that they are an extremely trustworthy office. It's not that I or even anybody on this panel necessarily always agrees with them, but they do things well, and they do things in an extremely trustworthy manner. And in today's age of disinformation, I think all of us have an obligation to try to support those offices, those institutions that are trustworthy. So congratulations, Paul, on another great job. So I say my overall theme is that Medicare can't be considered as just a Medicare issue, and can't be considered in isolation from the rest of government. I'm going to point to some aspects in which Medicare financing isn't just a Medicare issue. Medicare health costs aren't just a Medicare issue, and Joe already made some reference to that in his comments. And that hospital insurance reform by itself, which I'm sometimes afraid the trustees' reports would call us to do, could actually exacerbate problems rather than help solve them. So I'll try to go through this fairly quickly. Now, in the financing of healthcare, here's a chart that Paul updated. They put it in the trustees' report. I think it's a great chart. It basically shows 6 sources of financing for Medicare. The deficit number, by the way, at the top is a HI deficit. It's not the overall deficits of the federal government that might finance Medicare because they're hidden here in the general revenue transfers. So this is a terrific chart, but even listing only 6 sources of finance can be a little bit confusing to a beneficiary. So if you talk to a beneficiary of Medicare, they can be subject to up to 12 different means of financing that paid for their benefits. Well, they paid the payroll tax when they were working, although the payroll tax did not cover most of their Medicare expense, but it covered some of or most of their hospital insurance expense to date. Then if they're retired, they may be subject to taxation of OASDI benefits. That's a little confusing because that's an income tax, some of which is paid over to the Social Security Trust Fund, and then some excess amount is paid over to the health insurance part of Medicare. And then if you remember in the previous chart, we had something called premiums. But again, if you have relatives like I do who might be subject to more than one of these premiums, there's a standard Part B premium. There's a standard Part D or drug benefit premium. And then some higher income people could be subject to something called a monthly adjustment amount, income related monthly adjustment amount. They don't really know what IRMA is. And there's 2 of those, one for Part B and one for Part D. So there's 4 sources of Medicare premiums. There's state transfers, which isn't a big item, so most individuals won't notice that. And then the general revenue transfers, again, going back to this chart, are really a little bit misleading too, because they're really not all revenues. They're basically actual revenues that are coming to government. And then there are the deficits, which technically the budget people define as receipts, such as borrowing from China. It's not really a revenue source, but it's a receipt source if the money's coming in. And so these general revenue sources come in. Then, of course, the individual has to pay for a supplemental plan, has co-payments, and has out-of-pocket payments. So when a typical beneficiary is subject to all of these sources of financing, they're confused, but not only are they confused, so are the members of Congress. So if you ask them, how are you going to finance Medicare? They don't really fully understand this. And one of the dangers I'll get to later is if we're going to do HI reform, would we want to add on a 13th form of financing? And would that help us bring the system into balance? I should say in this chart, the nice thing about this chart that Paul came up with is that the total financing there, you see, goes right in line because it's counting deficits. It goes right in line with spending. And basically, it's the basic budget aspect that whatever you buy, you have to pay for. Now, suppose we decided we were only going to have one means of finance just for Medicare. This doesn't even count the rest of healthcare expenses in the economy. Well, if you look back at that chart that moved up there somewhere near about 2040, the chart says that Medicare expenses will be about 6 percentage points of GDP. Well, if we decided we were going to pay for that through one means of finance, it will require roughly all of the Social Security tax that goes both for Social Security and Medicare to finance. That is, it would take about a 15% payroll tax rate just to pay for Medicare. Or if you want to pay for it through the individual income tax, it'd take about 3/4 of all individual income tax revenues. So when we're talking about financing health insurance or hospital insurance, or talking about financing Medicare, we have to understand its impact even through the financing system on the rest of what we're able to finance as a government. One of the things I'm working on the side, I'm not covering a lot in this talk, is when I examine the growth in spending by the federal government, basically for about the last 40 years, 80% of all the growth in real spending has gone for healthcare, Social Security, and I'm talking about domestic spending increase, and essentially only 20% for the rest. So we talk about a lot that's going on in government, from squeezes on individuals, on the working class, what's going on with student loans. All of these are related to these extraordinary growth in these particular sources of spending for the government, which are largely centered on retirement and health. Again, thinking about this in terms of a balance sheet, this is a balance sheet. I'm not sure people can read the small numbers here, but over here on the right, we have 2 sources of financing for Medicare. And over here on the left, we have Medicare expenditures. So the Medicare expenditures are roughly running about $600 billion more than their direct means of financing. And that's largely as Paul pointed out, the cost of the supplemental medical insurance or the Part B and D parts of the program. Well, where does that 600 billion come from? Well, since every dollar we spend has to come from somewhere, it has to come from either other government receipts, and here I'm not defining this as general revenues, or it's coming out of this deficit. This is 2022 of 1.4 trillion. How much out of each one, we don't know. But there's actually a third source that I alluded to earlier, which is the other way that this sheet comes into balance is a lot of other government spending, if you track it over the last few decades, has been in significant decline, particularly programs for children or working families and other groups like this. So this excess here has to come out of either, go to the next slide, it has to come out of either higher receipts, out of a deficit and borrowing from somewhere, or it's coming out of declines in other parts of government. I'd say it's actually been coming out of all three, at least if we look at the history and try to tease what's coming out. Now, Medicare sounds unique in terms of all government programs. It actually has given or passed on the power of appropriations more than any other program, essentially to the private sector, to both providers who often can set prices or determine new goods and services that we have a right to buy, and sometimes consumers, so that when you and I decide that, yes, we really do want that extra healthcare and we go receive it, we automatically force government not only to pay for it, but we force one of those means of financing to come through and actually cover it. And Medicare is somewhat unique in that regard, or I should say the health programs of government are somewhat unique. If you think of something like housing, they operate within a budget. They might have some open-endedness with respect to the number of people that can qualify, but even in housing, they have caps on the number of people who can qualify. They have caps on the amount that can be spent. In Medicare, we don't get it. We come in the back door, we make it open-ended, and then we try to come in through the back door and create these rules that try to basically close off the growth in spending. But by passing on the power of appropriations, essentially, we're operating with systems that don't really operate with much in the way of budget constraints. And so the estimates we see in something like the actuaries reports or the trustees reports are just guesstimates as how this world will operate in this somewhat open-ended system. Now, given all that background, if Congress decides it's only going to deal with the hospital insurance deficit and not deal with the other 600 billion and growing expenditures in SMI, it could actually exacerbate some problems. For one thing, you might have a solution that gets at some inefficient payment system. Some people argue, for instance, that Part C of Medicare pays excessive benefits relative to Parts B and D. If Congress decided it wanted to go after that, then that has an impact on Part B and D. If you're only going to deal with HI or hospital insurance alone, you might be reluctant to take on that type of reform. It also weakens what has been meant to be the trust fund aspect of pressure. It's the trust funds initially were designed so that when you faced a limit, you were going to deal with it. If you only do HI reform and you still allow deficits to grow elsewhere, then you're not allowing that trust fund mechanism to work very well. As I've already mentioned, it could add confusion and inefficiency to a confused and convoluted panoply of means of financing, and it can add pressure, continue to add pressure to the rest of the budget. So I'm going to add a final note here. I think my time is up, is that reform of Medicare benefits, and this is just a note of optimism, reform of Medicare benefits does not necessarily mean a reduction in benefits for anyone. It basically means, at least on the benefit side, a slowdown in benefit growth when the non-elderly, at least by some measures, at least measures that count healthcare at cost, by some measures, the elderly have become richer than a lot of the non-elderly whose programs are often being squeezed. But the main point is what we're mainly talking about here, slowing down perhaps the growth of benefits through some better budget mechanisms. We're not necessarily talking about cutting off anybody's real level of benefits. And with this actually just shows you the growth, this graph, the growth in Social Security and Medicare benefits over time. For a couple today receiving about $1 million worth, a millennial couple being scheduled to get $2 million, which I think is unlikely to happen in the future. So in conclusion, Medicare financing isn't just a Medicare issue. Medicare health costs aren't just a Medicare issue. HR reform could exacerbate many problems. And the best Medicare reform might be undertaken with a broader budget of elderly programs that actually could make a number of elderly better off. And it might be undertaken within reform of the budget as a whole. I think the least likely scenario for something good happening is a reform that only tries to address hospital insurance by itself. And my contact information there is below, again, if you'd like some further information. Thank you.
Thank you, Gene. Much appreciated. Paul Vanderwater, you're next. Do we have Paul?
Yes, thanks. I was just unmuting myself.
Okay, great.
If Gene said that his comments were at the 30,000-foot level, I'm going to try to bring things down a little bit closer to earth. The trustees report and today's discussion focus on financing Medicare, that is, how to pay for it. But we must not lose sight of Medicare's strengths and accomplishments as well, particularly in the area of providing health coverage and holding down costs. In the coverage area, it's important to note that thanks to Medicare, seniors are the one group in the population with virtually universal health coverage. The uninsured rate of people 65 and over is just 1% of that population, compared to 10% for those in the younger age bracket, 45 to 64. Medicare has also scored well in the cost area, namely that it's generally outperformed private health insurance in holding down the growth of healthcare costs. Over the past 3 decades, Medicare spending per enrollee has grown by 5.1% a year, compared with 6.1% a year for private health insurance. As we craft solutions for Medicare's financing shortfall, it's also important to keep in mind who Medicare's beneficiaries are. Juliet's going to say more about this, but I want to make a couple of points. First of all, beneficiaries tend to have modest incomes. Medicare households, for Medicare households, the median income is about $30,000 per person. And 1 in 4 Medicare beneficiaries has an income of less than $17,000 a year. Now, even with Medicare benefits, beneficiaries still have significant healthcare spending. Medicare households spend about 15% of their income on premiums and other out-of-pocket costs, compared to 7% of income for those under age 65. And 1/3 of beneficiaries spend more than 20% of their income on healthcare costs. That's because Medicare has significant cost sharing and doesn't cover certain items that are important to seniors and persons with disabilities, such as dental, hearing, and vision benefits, and many long-term supports and services. These facts suggest that we should avoid shifting more costs to beneficiaries as we think about how to improve the financing of Medicare's hospital insurance program. Another key point is to be sensitive to how much the political system can accomplish. I've heard this referred to as aggressive incrementalism rather than trying to aim for comprehensive reforms. The immediate problem is the projected depletion of the hospital insurance trust fund, which, as Paul Spitalnik said, pays for hospital inpatient and post-acute care. Otherwise, in around 2028, financing will become insufficient to pay for, or become sufficient to pay for only 90% of benefits. Now, Medicare's program for physician and outpatient costs, as Paul also pointed out, and for prescription drugs, have a separate trust fund, and for those parts of Medicare can't run short of funding because beneficiary premiums and general revenue contributions are set at levels which are sufficient to cover spending. Now let's consider cost growth. As Paul and Gene have pointed out, Medicare's costs for all parts together are projected to grow faster than the economy, but that's true of healthcare costs generally. Making the healthcare system more efficient is a problem that needs to be addressed. If the steps to improve the financing of HI also help to slow healthcare cost growth, so much the better. But it isn't necessarily a requirement. Similarly, reducing federal deficits is a key fiscal policy goal, and stabilizing the size of the federal debt relative to the size of the economy. Many of the options for strengthening HI would also contribute to meeting that goal, but again, it doesn't have to be a requirement. With these points in mind, let me identify many of the options that are available for strengthening HI financing. Here are a few of them. First of all is a proposal that the Biden administration has made to fill the gap in the tax system. The Biden proposal would extend the life of the HI trust fund by many years. And here's the background. High-income taxpayers pay a combined Medicare payroll tax or self-employment tax of 2.9%, plus an additional Medicare tax of 0.9% on earned income above certain thresholds, for a total of 3.8%. At the same time, there's a separate 3.8% tax on net investment income, which, because of various congressional rules, wasn't dedicated to the Hospital Insurance Trust Fund at the time when it was enacted. A loophole, however, allows some types of business income of high-income taxpayers to avoid both the Medicare self-employment tax and the net investment income tax. The Biden administration proposes to close that loophole. In addition, it would direct both the additional revenue and the existing revenue from the net investment income tax to the Hospital Insurance Trust Fund. I'd note that the House passed reconciliation legislation the House adopted last year includes a provision that would also would close this tax loophole, but would do it in a way that would not provide any additional income for hospital insurance. Another way of improving the financing of hospital insurance, which is an indirect way of financing more Medicare spending from general revenues, would be to remove some category of spending from hospital insurance and move it to a separate program financed with general revenues, or to move it to Part B, which was already financed about 3/4 with general revenues. The Trump administration proposed just that sort of a shift for graduate medical education, and the Obama administration proposed reductions in spending for graduate medical education, although without shifting it to a separate program or to Part B. Still another way of improving HI financing would be to reduce provider payments. Reducing excessive payments to healthcare providers can make an important contribution to improving solvency in the medium term. For example, the Medicare Payment Advisory Commission and both the Obama and Trump administrations proposed scaling back payments to post-acute care providers, including skilled nursing facilities, inpatient rehabilitation facilities, and home health agencies, which are all too high relative to the cost of care. Still another way of improving HI financing would be to reduce overpayments to Medicare Advantage plans. Medicare beneficiaries, as has been pointed out, may choose to receive their hospital and physician benefits either through traditional Medicare or through private Medicare Advantage plans. Medicare's payment system attempts to correct for differences in the health status of plans enrollees through risk adjustment, but MedPAC and other analysts estimate that Medicare overpays Medicare Advantage plans compared to traditional Medicare because of the way plans code their enrollees' health status. And last but not least, of course, an option would be to raise the payroll tax rate. The hospital insurance deficit, as Paul Spitalik pointed out, is estimated to equal 0.7% of taxable payroll. That means that Congress could close the projected funding gap by raising the Medicare payroll tax rate, now 1.45% each for employers and employees, by just 35/100ths of a percentage point to a total of 1.8%. Now, to summarize and conclude, Medicare provides near universal health coverage for seniors and those with work disabilities at a reasonable cost. Because most Medicare beneficiaries have modest incomes and significant health spending, we should avoid shifting more healthcare costs to beneficiaries. The immediate Medicare financing problem is the projected depletion of the Hospital Insurance Trust Fund. Closing the HI funding gap may serve other important objectives at the same time, such as reducing the budget deficit or slowing the growth of healthcare costs, but it need not do so. Many options are available for strengthening the financing of hospital insurance. And although Medicare finally is not facing a financing crisis, Congress should not wait till the last minute to act. Acting sooner rather than later to improve Medicare's ability to provide the full benefits on which people rely would cool overheated rhetoric and bolster public confidence in this important program. Thanks.
Thank you, Paul. Appreciate that. Well, we actually have lots of time for, we will have lots of time for discussion, but next, Juliet Kubansky, please.
Thank you, Joe. Let me thank you and AEI for organizing this briefing each year about the Medicare Trustees report and giving us all the opportunity to see and hear from Medicare's chief actuary about the financial status of the Medicare program. And thanks to you, Paul, and your colleagues at the Office of the Actuary for the intellectual capital and the sheer number of hours that I'm sure it takes to produce this report each year. My remarks today center on two main themes. One, that focusing primarily on the Medicare Part A trust fund insolvency date and paying less attention to other key Medicare spending trends detracts from our ability to address Medicare sustainability in a meaningful and comprehensive way. And my second main theme is that in discussions about proposed options to put the program on more solid financial footing, consideration of the implications on beneficiary affordability and access would be helpful in light of current affordability challenges that beneficiaries face. So regarding my first point, there are certain numbers that come out each year that we obsess over in the world of health policy, like national health spending as a share of GDP or the average cost of employer-sponsored health insurance. In Medicare, it's the insolvency date of the Part A Hospital Insurance Trust Fund. This obsession isn't totally misplaced. It is an important number, and it tells us something important about the balance between spending and financing of hospital benefits for Medicare beneficiaries. But it's only one way of measuring Medicare's financial status. And because it only focuses on Part A, it doesn't present a complete picture of the total program spending and revenues. The insolvency date is a moving target. It bounces around quite a bit over time, though at least within the last 5 years, insolvency has been no more than 10 years away. But the date is quite sensitive to economic conditions since the payroll tax accounts for most of Part A revenue. So a healthy economy is good for the trust fund, as we've just seen in the past year. And a bad economy has the opposite effect, like in the first year of the COVID pandemic. But when it comes to spending, outside of a global pandemic driving down utilization or reductions in provider payments that Congress infrequently adopts, this component of the trust fund tends not to bounce around, but mainly just goes up. So in efforts to extend Part A trust fund solvency, getting a lot of savings on the spending side of the equation means cutting a lot, and getting more revenues means hoping for economic growth or taking the highly unusual step of raising taxes or other revenue sources. So focusing just on the status of the Part A trust fund, we confront rather uncomfortable options on both sides of the equation. But stepping back, Part A is only one part of Medicare, and it's no longer even the biggest part. Instead, spending on Part B, physician and outpatient services, now accounts for a larger share of Medicare spending. So talking just about Part A and ways to bolster the Part A trust fund takes the focus off of where more of Medicare expenditures are going. Additionally, a growing share of Medicare dollars are going to private plans through the Medicare Advantage program. By the end of this decade, more than half of all Medicare spending will flow through Medicare Advantage, not traditional fee-for-service Medicare. We are witnessing the foundation of Medicare changing from one where traditional fee-for-service was the norm and Medicare private plans were a sideshow, really, to one now where Medicare looks more like a marketplace of private plans, and traditional Medicare may be the refuge for a relatively small but probably relatively sicker subset of people on Medicare. This matters because according to the Medicare Payment Advisory Commission, under the current payment system, we are paying 104% more per capita for an enrollee in Medicare Advantage than spending would be on that same person in traditional Medicare. This is a smaller overpayment than it was a decade ago, but it's still an overpayment. Therefore, rising enrollment in Medicare Advantage puts even greater financial strain on Medicare, including the Part A trust fund. Now, there's been talk in the past about transitioning to a so-called premium support system that relies more heavily on competition between private plans and traditional Medicare, and we can certainly talk more about that if there's interest and time. I would just note that this isn't a guaranteed path to savings if we continue to pay plans the way we do now. A premium support system could save money if plans were paid differently, according to the Congressional Budget Office. But that could also impact the generosity of supplemental benefits that plans offer, which is one reason behind growing enrollment in these plans. So now to my second main theme, I want to introduce a few beneficiary-focused numbers into this discussion related to the affordability of healthcare costs. I think these numbers are worth highlighting because as policymakers consider options that might shift more costs to beneficiaries in the form of higher cost sharing or higher premiums, for example, as a path to greater financial sustainability for Medicare, it may also be worth considering the reality from an affordability perspective. First, as Paul has already mentioned, half of all Medicare beneficiaries have per capita income around $30,000 or less, which is somewhat less than 250% of poverty. For beneficiaries in communities of color, median income is significantly less than $30,000. And according to Medicare's actuaries, Medicare premiums and cost sharing for Part B and Part D today already consume nearly 3 out of every $10 in Social Security benefits that beneficiaries receive on average. This share has almost doubled over the past 20 years. While most beneficiaries do have other sources of income, in addition to Social Security, beneficiaries also incur other costs besides Part B and D, including costs for services not covered by Medicare, notably dental care and long-term services and supports. These cost-sharing requirements and gaps in the traditional Medicare benefit undermine the financial protection currently provided by Medicare, particularly for some groups of beneficiaries, including those with no supplemental coverage, who are more likely to report cost-related problems, like trouble getting care due to cost, or delaying care due to cost, or problems paying their medical bills. And although Medicare Advantage plans do have an out-of-pocket cap and offer additional benefits, MA enrollees are more likely to report cost-related problems than beneficiaries in traditional Medicare with supplemental coverage. Exposure to high out-of-pocket costs is also an issue for Medicare Part D drug coverage, where there is no out-of-pocket cap and beneficiaries can pay thousands of dollars for many of today's high-cost drugs. There is bipartisan support for modifications to the Part D benefit that would cap out-of-pocket costs. And our KFF analysis has shown that a $2,000 cap would have helped 1.2 million beneficiaries in 2019 who had out-of-pocket drug spending above this amount. Taken all together, the cost of premiums, cost-sharing requirements, and gaps in the Medicare benefit package, combined with relatively low incomes among the Medicare population, can result in beneficiaries devoting a substantial share of their total household spending to healthcare costs. As Paul has also already mentioned, Medicare households spent 15% of their total household budgets on healthcare in 2020, which is twice the share among non-Medicare households. So while lawmakers may in the future discuss various options to ensure Medicare's financial sustainability, I think it's no surprise why their more recent policy discussions have focused on proposals to cap out-of-pocket drug costs or add dental and vision and hearing benefits to Medicare, and not on addressing trust fund solvency, because the current gaps in Medicare coverage are more pressing challenges from a beneficiary perspective. But addressing these gaps would mean spending more money than currently projected, not less. I'll just end by saying that we have many resources on Medicare on our website at kff.org, which I invite everyone to explore. And with that, I'll hand the virtual mic back to you, Joe. Thank you.
Thank you very much, Juliet. You've hit the nail on the head where, on the one hand, we don't want to add more financial burden to Medicare beneficiaries, in particular, lower income Medicare beneficiaries. But on the other hand, we do have a financing problem. It seems to me that in the past, other than ideas like changing payment systems, adjusting payment systems, we really haven't had good ideas coming out of the Medicare program in terms of how healthcare is actually delivered. I think that could be a political failure, but it may be a failure of imagination as well. How would you do it? I think is a fair question to ask me, and I can't answer that very easily, and I don't think many people can. Well, we have time for some discussion, and maybe to kick it off, maybe a little bit of back and forth on Jean's point that the Medicare problem is a broader problem. It's not just a program issue. It's really an all government spending and financing problem. And how does that mesh with some of the comments that Paul and you sort of alluded to about kind of looking at the Medicare program and looking for reforms that are narrowly constrained to Medicare, as opposed to a more broad view that, as Jean suggests, might look at social services and other kinds of spending that affect the Medicare population. So maybe I'll pick on Paul, since Paul really had a kind of a laundry list of things that you would focus on Medicare specifically. What do you think of Jean's point? And do you see some ways to possibly find some synergy between Medicare and the other kinds of federal programs that provide support to the Medicare population?
Jean is right, of course. Healthcare spending is a big part of the economy. Medicare is a big part of healthcare spending, as well as a big part of the federal budget. And the growth in the cost that Medicare is imposing both on the economy and on the federal budget are significant. So to the extent that we can make progress in, as you just said, Joe, in changing the healthcare delivery system that would get at that underlying cost growth, so much the better. The point I was making, however, was that we shouldn't, we have this immediate problem of the hospital insurance trust fund depleting its reserves in the near future. And we shouldn't hold up the relatively smaller steps that could be taken to solve the HI financing problem while we're waiting to solve the big problems that Gene has identified.
Yeah,
Joe, can
yes, please.
So Paul said I was right at some level, and I agree. Paul is right. I'm certainly not advocating not solving the HI problem. We're not going to cut off beneficiaries' benefits and down the road. And we're certainly, the sooner we act, the better. So I agree with that. I even agree with many of the policy options that he put forward. I suppose my slight area of amendment would be, in a lot of cases, I don't necessarily want to do them just for Medicare. So for instance, there are a number of tax provisions I think make very good sense for the government as a whole, as a revenue proposition. They're paying for other parts of government. Dedicating them to HI sometimes narrows down, not just narrows down the issues we're confronting up front, but actually can cause you problems down the road, because then you can't really fix the tax policy as a tax policy, because now you've got this dedicated source of revenues over there. So it seems to me that what we're in the midst of is a grand dilemma. We, for years, have been running deficits in the government as a whole. And when you run deficits, it sort of allows people to excuse themselves from dealing with the aspects of scarcity. And in Medicare, we're doing the same thing. We're running deficits, and we don't want to deal with the fact that resources are scarce and we have to decide what to do. So if you take healthcare, let's think about healthcare. If you take healthcare spending for the economy as a whole, if my numbers are right, healthcare spending, average healthcare spending per household is now approaching about $30,000 a household. You remember Julie had a number of 30,000 as the median, I guess, cash income of elderly households. So, somebody's paying that 30,000. That's an average. So we treat healthcare expenses as catastrophic if there's 2 or 3, and for a lot of families they are, but on average we're paying 30. And we're doing this partly because we're dodging this issue of scarcity and deciding what best to do with resources. So I suppose the only difference between Paul and I is I would be as comprehensive as possible in trying to solve the HI problem, but he's right. You still got to solve the HI problem, and let's not neglect it.
I agree. I mean, the problem, though, as we've seen from time to time over the last 20 or 30 years at least, is that the solution to the HA problem is usually kick the can down the road rather than anything that really changes much of anything in terms of the way healthcare is delivered, or in terms of the way Medicare pays for healthcare. The worst dodge that I remember was the shift of some services that were in Part A into Part B in order to nominally push the insolvency date for Part A out a few years without actually affecting either the services that were delivered or the way they were delivered. So I think I would argue that we need more thoughtful policies than that sort of thing. I agree. I find myself agreeing with everyone here on this. Congress is going to deal with this. We're not going to have a situation where the Part A trust fund is going to hit zero in the current year. That's just not going to happen. The question is, when they do the superficial policy that is virtually inevitable, will they then say, okay, we've done enough, we don't have to do any more? And the problem is that the rest of Medicare, which, as several of you pointed out, Part B and Part D are really the growing portions of the Medicare program. Well, those parts of the program do not have the same sort of political warning that Part A does with a with a trust fund depletion date. So there's really no signal to politicians to do what they really ought to be addressing, should have been addressing all along. I think it's a real problem. Juliet, did you want to dig into this at all?
Well, yeah, I think we're talking about the insolvency date of the trust fund now, 2 years further out than it was last year. And last year it was, within 4 years of depletion. And we didn't really hear any discussion among policymakers then about, what to do about, dealing with the imbalance between spending and revenues. So, I think many policymakers may sort of secretly be breathing a sigh of relief now that they don't have to take on this difficult challenge. As I was discussing, how do you do this? Do you raise taxes or draw on other sources of revenue? That's not really a conversation that I think many policymakers want to entertain. Spending reductions in the form of, benefit reductions or payment cuts to providers, as the trustees outlined, even current payment schedule may not be sustainable. So it's quite a conundrum that I think we're confronting. But we really cannot continue to kick the can down the road, as you said, Joe. Otherwise, we will end up sort of with kind of budget gimmicks to deal with a problem that will not get us as far as we need down the road. So I think, when we look at it from a trust fund perspective, we're left with not great policy solutions. Stepping back, looking at where more of Medicare's dollars are going, I think is where a more fruitful discussion is to be had in terms of, overpayments to Medicare Advantage plans, for example. But unfortunately, there's not a lot of appetite for talking about Medicare Advantage payments either. So we're just, I think, really stuck when it comes to a healthy discussion about options to deal with Medicare's financing problems.
Yeah, agreed. So we're stuck, at least with regard to Congress. And, as you said, the reason is obvious. It has something to do with politics. And of course, when our members of Congress not running for office, the answer is they're always running for office. So in a sense, we can't really count on them to necessarily take the bold step, but there may be another alternative to this in the sense that the Affordable Care Act established the Innovation Center, which has tremendous authority to try out new ways, not just in the Medicare program, but we're focusing on Medicare here, try out new ways that don't just rely on adjustments in the current payment systems and can also encourage the development of kind of new business models for healthcare and Medicare and potentially for the rest of the healthcare system. I have my own views about that, but would invite the panel to make comments about how they're doing. Anyone want to take a chance? I'm always willing to blurt out that I don't think they're doing a good job at all.
So I'll start, and I'm not sure this was geared towards me, but I'll jump in anyway. And that's exactly where I wanted to go. When the discussion of how can we have these broader policy changes to actually constrain the cost growth, for Medicare program healthcare costs in general. So there has been a lot of really great work coming out of the Innovation Center. That work is largely in trying to transform payment systems from pay for volume to pay for quality. And they've done, you can't argue whether they've had great success or mixed success, but they've at least introduced a number of programs where there has been at least that transformation. Now, whether that is going to materialize in payment reductions, That is something that there just hasn't been as much success in. And I think when we're talking about broader programs, it's kind of went through today. We've identified, the panel has identified a number of instances where there are opportunities for expansion of Medicare services into either constraints and out-of-pocket limits, or in services that aren't covered that were broadly recognized as would clearly benefit the Medicare population. There's lots of interest in exploring expansion of potential coverage that will clearly increase costs. Whenever the discussion turns to what are the areas where we can actually reduce costs, reducing costs typically include reducing someone else's revenue. When people's revenue is on the chopping block, there tends to be a lot of interest in protecting that. And so where there has been, and I would give credit to the CMMI, the Innovation Center, for at least shifting some of the focus on some of the incentives or some of the directives of what is being achieved, shifting from that volume to quality is clearly a step in the right direction. However, constraining, actually reducing those dollars, that does seem to be a greater challenge.
Oh, I have a question for you. I really can answer it. Or anybody. I've been struggling with the issue of whether Medicare Advantage could do what I think a lot of budget people thought might be its possibility. And that is that since it operates within a budget constraint, that it should have certain incentives to be efficient. Operating against it is the open-endedness of the rest of the system. So a doctor working in Medicare Advantage wants to be paid the same as everybody else. Or if there's a monopoly hospital in Boston, they control pretty much the prices that are going to be set by everybody. But the idea was that operating within a budget would give an incentive to be efficient, and the notion that individuals could get some money back, hopefully goes beyond Joe Namath advertising on TV about why you should get Medicare Advantage, but would encourage them to choose lower cost plans. And there was a case many years ago, I might even still be true, where government employees were offered low and high cost plans, and they consistently chose lower cost plans because they were made to pay the full cost of the difference. So I'm just curious, anybody, whether there is within Medicare Advantage this ability somehow to make it into a more competitive model where people could help reduce the cost of Medicare by choosing a lower cost plan, so the voter, the beneficiary, didn't feel like it was just something being imposed on them from above that was taking away something from them. It's a question.
Yeah, I think that's a fair question. The marketing rears its ugly head here when it comes to Medicare Advantage. There's a good reason why Medicare Advantage plans and Joe Namath constantly tell you that you can have coverage for dental, eyeglasses, hearing aids, and so on. Those are tangible things that the average person can really identify with. The problem with savings is, I think most people are a little skeptical when the government says we're going to send you some money. Now, the other thing that Medicare Advantage, some Medicare Advantage plans do, which does constitute actual cash savings, is they will say, well, we'll offer you a zero premium plan. That's money up front. I think the one of the challenges that the Medicare program has, and CMMI would have, is if you were going to try to redesign certain aspects of the Medicare program to give concrete financial rewards to people that they recognize as rewards to them, the money would have to show up early, on time. They'd have to be aware of it. They'd have to see what the alternatives were. And then they'd have to evaluate whether they'd rather just pay somewhat more and have the somewhat vague promise of additional benefits. So I think the very vagueness of what the benefit package is for Medicare Advantage plans kind of counters this idea to some extent. And so it's one idea that some friends at Brookings and I invited me in on this paper, suggested that Medicare Advantage plans might be restricted to a more limited range of options to make it easier for beneficiaries to understand better what they're comparing with what. That might help your suggestion. Any other thoughts on that?
I would just add, I think there is the potential within Medicare Advantage to achieve greater efficiency, but not if we continue to pay plans the way we do now. That is a path to
Right.
higher spending
Right.
than in fee-for-service. And so there needs to be a discussion about ways to modify the Medicare Advantage payment system so that we don't have a system where basically all plans are receiving quality bonus payments and we're continuing to pay more so plans can offer more generous supplemental benefits that draw beneficiaries out of traditional Medicare into Medicare Advantage plans.
Yeah.
So I think that discussion is what needs to happen in order to, find savings within the Medicare Advantage program.
So we have a few minutes. We only have a couple of minutes left, and I neglected to really study the questions that came in. I apologize to the audience for that, but let's pick up. Actually, here's sort of a basic question about how the trustees incorporated higher inflation and an expected higher provider payment updates for the next several years. And I guess I would refine that question a little bit to raise the issue that the assumptions, the economic assumptions may be a little optimistic. With supply chain issues and so on, I think the public is experiencing pretty substantial inflation right now, and it doesn't look like that's going to abate very soon. We also had a downturn in the economy in the first quarter of this year, which doesn't necessarily bode well for at least the next few years in terms of revenues from payroll revenues. So maybe Paul could address that complicated question.
I do know we only have a couple minutes, so I'll do my best to do it as quickly and as efficiently as possible. The trustees made specific references, actually somewhat unusual, that the assumptions for the 2022 report were essentially set in mid-February. So this was a point in time where there were clearly signs of inflation. This was, pre-Ukraine, pre some of the supply chain being more acute, over time, and so it clearly those assumptions were set on the front end of some of those concerns that you raised there, and so it is very well possible that the experience for 2022 is almost certainly going to be worse from an inflationary side, and certainly higher inflation directly leads to higher payment updates. Payment updates generally are not as high as will not be as high as some of the CPI figures, just because some of those the CPI figures are really being skewed towards some energy and food-based products, as compared to we're seeing less so on the wage side, which is truly how some of those updates. So it is very possible that next year's report there will be some negative experience for 2022, in particular for some of those economic effects. But as we've seen, the economic changes in current economy is moving relatively quickly, and so we'll see where things fall throughout 2022 as we lead into the 2023 report.
Yeah, thank you very much, Paul. I think we've just about run out of time. This has really been a very interesting discussion. I appreciate everyone's contributions and insights to this issue. I'm confident that we have not resolved any of the problems, but we've certainly pointed in directions that policymakers and we ourselves should spend more time concentrating on. There are issues that need to be dealt with. This is an incredibly important program. The leverage of Medicare and with regard to the rest of the health system cannot be overstated. And so having developing sound policies for the Medicare program that deal with the fiscal issues, but also preserve the best part of the program for beneficiaries is incredibly important and will potentially lead the way to other reforms in the rest of the healthcare system. Thank you very much. And thanks to the audience for joining us.